so much for joining us today. My name is Yoshi Domoto. I am the Executive Director of the Japan America Society of Georgia, and I'm so thrilled to have so many of you joining us today, tuning in to learn about COVID-19, what's happening in Japan and the US, and where we go from here. Before we get started, I would like to thank all of our sponsors and our promotional partners. First of all, the Consulate General of Japan here in Atlanta. Thank you for their support on making this program possible. And our promotional partners, the Georgia Tech Center for International Business Education and Research, or Georgia Tech Cyber, Global Atlanta, our favorite Global and Atlanta media partner of ours, and then 11 Alive as well. Without further ado, we would like to introduce the special guest panelists we have for today. From Georgia Tech, we have Dr. David Koo. He is the Chair of Engineering and Entrepreneurship and Professor of Mechanical Engineering. He has an active research interest in cardiovascular disease, pathophysiology, and treatment. He has additional interest in commercialization of novel medical devices through startup companies as well. And all the way from Japan, we have Dr. Daiichi Mori. He is an infectious disease physician at Osaka University Hospital, and he also serves as technical advisor at the COVID-19 headquarters of the Japanese Ministry of Health, Labor, and Welfare. Thank you both for being with us today. Dr. Koo, would you like to start off and discuss all the American response to COVID-19?
All right. Thank you very much for inviting me to talk about the U.S. response. Unfortunately, I will say that the U.S. response has been poor, and we will talk a little bit more about how this could be. But essentially, we knew, the CDC knew about the COVID initial outbreak in China very early on, but there really wasn't a coordinated effort from our central government to get people to do simple things like wear a mask, have social distancing, and do hand washing. There has been a plurality of opinions by many people in our government, and so there wasn't a coordinated response. Generally, public health works best if there can be a coordinated response against the pandemic, but that really wasn't done. Consequently, such things like travel, even though it was initially banned, there is very little control of that. So people continue coming into our country without any testing beforehand or after. And even if they are COVID positive, they're asked to self-quarantine in a very light manner so that very few people do it. So travel has certainly caused more of a distribution. Certain states have essentially not mandated masks, and most states actually do not mandate it, but they recommend it. And so that's a problem that it has followed what we consider the natural history of the disease. The natural spread is exponential growth. And so all the numbers in the US show essentially exponential growth with some plateaus here and there, but without restrictions, we see a large growth. And now we have some vaccines that are coming out, and unfortunately there's an uncoordinated response there as well, so that each state and each county within a state treats the distribution of the vaccine differently, so that even though there are like 20 million doses that are already sent out, only about 5 million have actually been administered. Hopefully it's getting better now. There's been discussion about whether there's a lack of supply, but with 4 times as much doses out there, and I don't think a lack of supply is the problem. So let me tell you about some other things that people have been doing in the US and trying to get more of a handle in spite of all the lack of coordination in the central government. One thing that I did right at the beginning, since there was essentially a lack of tests and a president that was asking us not to take tests, is that we developed a system that we could quickly sample people and see whether they had COVID or not, just based on their symptoms. And from that, one can find out within 24 hours whether a population has a high incidence or low incidence without having to do tests. This is back to similar types of testing that you could do it's called surveillance testing, but by just asking people. And I'll share 2 slides on you can go to countcovid.org and it asks for 6 simple questions and it takes about 30 seconds to do, but then you can get the incidents in the different counties by zip code and also know, like around the New York area, where there were high incidences of COVID and where there was low incidence. This was back validated against surveillance testing that was done in that area and is actually quite close to it. And it showed that that the incidence was much higher than people knew from the testing, because most of the testing was not surveillance testing, but it was used for just those people that came in to have tested, and that was much slower. Another thing we've been doing is a RADIX program in order to develop more tests. This was a program started by the US government, and Emory and Georgia Tech were part of this program. We received $35 million, but it was over $100 million throughout the United States to try and test the tests. Can we say which tests are better than others? I have had to block these out because we are required to keep confidentiality, but you can see that the PCR tests were in generally very good. We could test them to high dilution and they were still positive. But on antigen testing, there was a wide variety of rapid tests that were developed. Some of them show very faint positivity for non-diluted samples, and others show very still positive for very high dilutions. And that would suggest this is very sensitive to the different studies. And so we think that this is an important information to know, and these were used with both inactivated and live viruses, and also with patients, so that we had a good backup to see whether these rapid tests were indeed good or not. So I think I will stop there, and that gave you a little overview of some of the responses in the US, and we can talk later on about what implications that might have for the future.
Great, thank you so much, Dr. Koo. And I know early on in the pandemic, back in March and April, when there wasn't a lot of testing going on in the United States, you and your team kind of stepped up and created a kind of testing mechanism at the grassroots level. So we certainly thank you for all your support and all that you're continuing to do to fight the pandemic. So thank you. At this time, I would like to ask Dr. Mori to come on board to talk about what's happening in Japan. So Mori Sensei, ohayou gozaimasu, and thank you so much for joining us all the way from Japan.
Thank you, Yoshi-san. Great to be here. Let me share the screen. First of all, this is the epi curve of the daily confirmed cases in Japan. We have 3 major waves of infection. The first wave was last spring. At the peak of the first wave, we had 500 to 600 confirmed cases a day. The government declared a state of emergency on April 7th. Then the second wave was last summer. The central government did not take specific measures, but some local governments ordered a very soft lockdown. Finally, since last November, we have been in the midst of the third wave. The government issued the second declaration of state of emergency last week. Now we have 7,000 to 8,000 cases a day. There have been 2 major responses by the Japanese government. One is soft lockdown. The central government has declared a state of emergency twice for these soft lockdowns. Under the declaration, local governments advised the general public to stay at home and business operators to completely close their restaurants, bars, movie theaters, etc. These are all based on a law called the Act on Special Measures. However, importantly, this is not a mandate. The government can only give advice. Plus, additional soft lockdown and early closure of restaurants were advised by local governments, but this is not based on law, just optional action. Both the national lockdowns and local lockdowns were totally optional, but the national lockdown, which is based on a law, had more social pressure behind it. So more businesses comply. On the other hand, the government can require people who tested positive to be isolated in hospitals or hotels. Unlike the government's soft lockdown, this is a coercive response. Here are some data I can show you. Figure 1 shows the cumulative cases compared to Japan. The United States had more than 30 times the infection per population than Japan. To measure the impact of the infection on healthcare, we can look at the occupancy rate of COVID among the total hospital beds in the country. Figure 2 shows that the occupancy rate of Japan is much lower than Western countries. In Japan, it is 1.7%, and in the United States, it is 14%. However, the hospitalization rate in Japan is very high compared to other countries. This is because we have an isolation strategy required by law. Figure 4 shows that the burden of COVID on intensive care unit, namely ICU, is greater in the United States and France than in Japan. That's it.
That is very interesting to learn that although the number of cases in Japan is much lower than the US, if you look at the number or the percentage of hospitalization is much higher. So it's very interesting, but that's part of Japan's strategy.
Yes.
But speaking of the Japanese strategy, we will kind of go into our panel discussion now. But what did the Japanese do to keep the pandemic numbers at a reasonable level? I know you talked about a little bit already, but why is Japan's numbers compared to Europe and the United States and other parts of the world much lower?
There are many hypotheses to explain the difference. It's complicated, so we are still not sure, but one plausible reason for the difference is lifestyle. In Japan, wearing a mask is completely normal behavior, especially when you are around other people. This is just a common sense. It's not mandated by law. It's just voluntary. It's just about protecting ourselves, protecting our families, protecting our friends, co-workers, and eventually our community overall. Another possible reason for the difference is isolation strategy, as I said. In Japan, the government can legally require the people to stay in hospital, to be isolated in hospitals or hotels for all COVID positive patients, regardless of their symptoms, according to the Infectious Disease Act. This is a kind of coercive response based on law, not a voluntary basis. In the early stage of the outbreak, all patients were hospitalized, even if they were asymptomatic. However, in the midst of the third wave now, since November, we have not had enough hospital beds to accommodate all patients in medical facilities. So many local governments shifted their strategy to use hotels and sometimes patients' own homes with some condition. But still, we maintain our isolation all strategy. So, of course, costs incurred to the isolation are all paid by government. I think it was good for controlling community infections, because a big part of COVID is that some proportion of patients become spreaders while they themselves are asymptomatic. So I think those two reasons can explain the difference.
Could I ask, that I think that's really important. The masks and the isolations, those are clearly different things than that Japan was doing than the US. There are two other areas that I don't know really about Japan, and maybe you could help comment on it. One is the, was there any restriction on gathering, or at least did people try to gather less? And also, what about travel? Where was that unrestricted, or was there any restrictions there?
In terms of the mass gathering, under the declaration of state of emergency, government advised people not to do that. And for example, a sports event or concerts or that kind of things, government advised not to do that. But this is a kind of voluntary basis. Government did not have the police power or
Right.
cannot mandate to ban or everything.
During the summer, were there baseball games, and would lots of people go into the baseball stadium?
Yeah, but you know, baseball game, they have the national committee for their business. So you know, they basically they comply with the government's advice. So I don't think this is not a big issue in terms of the baseball or other very big you know, organizations. And another things in terms of the traveling, actually government urge people to travel around since the last summer to, you know, to stimulate the economy, you know. So actually, but government retrieved that policy in last month. There were strong criticism to those government's policy, because you know, this is not good for the controlling the community infection, because you know, mobility is closely related to the reproduction rate of spread. Right. So yeah.
Well, along those lines, Dr. Ku, a question for you. I know Japan's daily cases of COVID-19 is much lower than the US and other parts of the world. But how do you feel that the US healthcare system has managed higher numbers?
Well, the healthcare system actually, I think, has been reasonably good, other than the sheer number of cases creates a huge burden on the system. So I think Dr. Mori showed the 3 peaks. And if you look at the US, we also have 3 peaks, but they're just 30 times greater. And so if it's 30 times greater, it overwhelms the health system. We just really don't know what to do. There are not enough ICU beds for the very serious ones. And so there can't be enough for the people that are just symptomatic, because there's just no room. And I think that's what the goal was at the beginning, was to flatten the curve, as they say, at least have the overall numbers lower so that you could deal with it. The US health system learned to deal with severe cases very quickly. In the beginning, I think the death rate was higher, but since then, the death rate has come down, and the treatment for people is, I would say, different. When they first started coming in, there was a protocol to deal with patients that had respiratory distress. And that was to essentially put people on ventilators when they had a low oxygen content. And yet it seemed like they actually did better if you did not put them on the ventilator. And so it helped relieve the shortage of ventilators because we started to put fewer people on and actually got better results. But they didn't know how to deal with this new respiratory distress at the beginning.
Great, thank you so much. And moving on to you, Mori Sensei. So in terms of response to the pandemic, there is different viewpoints, different ways of looking at that. I know there's medical perspective, technological perspective. I know there's a lot of new medical technology that has been implemented, and also social responses too. But what are some of the most important things that the Japanese people and the Japanese government have learned since the pandemic started last year?
I think, in the last year that we didn't have enough technology parts, development, because we don't have the vaccine yet. Actually, the vaccine is not authorized by the Japanese government yet. And so, all we could do is, to adjust our lifestyle to the COVID situation. So, for example, we were advised to not to, go to restaurant with many people, and drinking and singing is a kind of risk behavior, that kind of things. Those, very basic precaution was the key factor in terms of the Japanese infection control.
Yes, speaking of singing, I guess the karaoke industry in Japan has been hurt very much by the pandemic, right? So, but Dr. Ku, a similar question. I know the U.S. has had a very different response to the pandemic, but what do you think some of the most important things that the U.S. has learned? I know we all have our own kind of Zoom webinars and Zoom. I'm sure we had our holiday gatherings via Zoom and sending kids to school through kind of virtual means as well. But what are some of the most important things that the Americans have learned, do you think?
Well, I don't know whether we've learned it uniformly because there seems to be really different isolated pockets, but we can see that the behaviors of people really has an effect on it. I think compared, I'll make a generalization that is definitely not true for everyone, but stereotypically, Americans tend to be very individualistic, and that's something that Americans are very prideful of. And so we often don't necessarily follow things that would be good for the whole and think more of the individual. And that's a situation where when you have a pandemic, you almost have to have the reverse. And my sense overall of the Japanese culture is that they are willing to think about the good of the society over the individual in some cases, or more in the general sense. In the United States, like where I live in Georgia, Atlanta is a big city and we have more cases than the rest of Georgia, but actually on a per capita basis, it's actually not so bad. There are other pockets around Georgia that have almost 10 times as much on a per capita basis. The numbers don't always reflect it because the absolute numbers are smaller because they're not as populated. But in those areas, there are strong individualistic attitudes towards not wearing a mask and not listening to any of the advice. So there was still lots of gatherings at restaurants and parties and things like that. We saw that at Georgia Tech. So I'm in a university setting. Before students came in, there was very little on campus because we had shut down. But for fall term, then all the students came back, and there is a culture in the United States for all the college students to party and drink a lot, and they like to do that. So the first 2 weeks coming back, you saw a massive spike in, it's an order of magnitude, 10 times as many cases. Once they all got sick, though, then they all settled down and stayed in their dorms and practiced much better behavior. And so that was good because it reduced the amount of incidents in the school. However, recently we have had the break and now we're all returning to school. And I wanted to see what is the incidence of COVID in the general population, or in that population before they actually arrive on campus. So they're all out in the community. Before the fall term, it was high. The students had about 2 to 3% incidence, and that's actually fairly high. And at that point, it reflected the community. And if you surveyed the faculty and staff, it was about that too. It was a little less, maybe 1.5. But in general, older people like me this past year have learned that we don't want to have COVID. And so most of the people that I know that are faculty and staff have not been on campus, and we mask all the time and we're careful going out. And I just surveyed the faculty and staff of Georgia Tech, and there is 0 symptomatic COVID right now, just 0. But on the student side, there is 10%. And those 10% were actually confirmed by testing as well. And of that, so it's a very high incidence of the students coming back. And so they will be spreading it quickly. Not only is it high incidence, but we know that young people tend to have it less symptoms, put it that way. And so even though they're 10% of COVID and they're positive by test, they actually, only 1/3 of them show symptoms. So we asked them if they have symptoms. So 2/3 are relatively asymptomatic compared to that. And so that's really a difference that we have to think of differently in the student population compared to the older population.
Yes, I know college campuses like Georgia Tech is a city within itself. So
Right.
that's very challenging and difficult to manage at the same time, especially after a break like what we just had. But Dr. Modi, so kind of asking you a question about, I know the Japanese response to the pandemic has been much better and much more positive than the US, but is there anything that Japan can learn from America and some of the responses that we've had here in the US, anything that the Japanese can learn in terms of pandemic response, crisis management, or the importance of global collaboration?
On the Japan side, we want to learn how US hospitals could change the allocation of healthcare provision from other diseases to accommodate COVID. Because as I presented, the United States has 13 times more incidence per population than Japan. So I calculated the occupancy rate, as I show you, the COVID among total hospital beds based on OECD and Oxford University data. According to these data, 14% of hospital beds in the United States are occupied by COVID. This is much higher than 1.7% in Japan. In Japan, we now have 7,000 to 8,000 newly confirmed daily cases. Newspapers every day say that our healthcare has almost collapsed in Japan. But compared to Japan, the word collapse is really hard in the United States. So it is hard to imagine, how the United States healthcare can handle such large numbers of COVID patients in addition to other diseases like heart disease, strokes, or cancers. I'm wondering, is there, any effect to these the normal other diseases healthcare provisions?
Yes, I think there has been a serious effect, as just as you see the numbers. So in the U.S., we have to now think about rationing care, who gets care and who doesn't get care. And I think it's really sad because it's just the sheer number of cases. You can, as you see, that we must have to deal with that. And so even as early as April, we knew we would have to ration care. And so back in April, a lot of hospitals stopped all their elective surgery and other cases like that. And that's had a large impact. And currently now it's all the staff is working overtime and their patients in the halls, and they tell you when you call, don't come for your annual checkup. Like when I had my annual checkup, they said, we'll schedule it for you sometime in the future, but we're not going to deal with you now. And a lot of people have been shifted over so that people that were, let's say, doing gastrointestinal diseases, they have to now deal with infectious diseases because there's just so many patients with that. And so it's definitely burdened the whole system. I suspect that when they do some large tallies, they'll be able to see that the other disease mortality has gone up over the year because I don't see how it couldn't. I know they're not being treated as much.
Okay, but you don't say it's a collapse anymore.
I wouldn't say it's collapsed yet. In places like Los Angeles, in the news, they are saying it's collapsing. So in places like Los Angeles, if you have a COVID patient and you have an ambulance, it's sometimes hard to get an ambulance to bring the patient in. And then about half of the hospitals are turning them away. They say, you have to go to another hospital. You can't come to the closest one because we are too full.
Okay.
So I would say that's a collapse of the system.
Okay. Thank you.
So we will have a Q&A session momentarily. So for all of our audience members joining in, feel free to ask your questions. I know you have a lot of them through the Q&A button at the bottom of your screen, and we will get to those as fast as we can. But before we go into our next question, so Dr. Ku and Dr. Modi, so kind of following up on our most recent discussion about the hospitals and kind of healthcare in both Japan and the US. The Japanese hospitals are generally much smaller than the US. So there's only 200 or 300 beds, I think, in Japan. So is that kind of one of the reasons why kind of the healthcare and the ability of the healthcare system to take care of patients, is that the big difference because of the capacity and the size of the hospitals in each country, you think?
For me?
Sure.
Okay. Yes, that's true. Compared to the United States, the Japanese hospital is very small. Their capacity, actually 200 beds is kind of the large hospital in Japan. So, in Japan, there are many hospital beds per population, but most of them are for the chronic disease, long-term. It's almost long-term care actually. Oh, okay. So yeah, so that's why we have almost collapsed with the very small numbers of confirmed cases. So those hospitals refused to accept those patients. So the burden of the COVID is just on the very small part of the hospitals. So that's the problem, the biggest problem now we have. Now we are facing this time. So government governments now are trying to amend some sentence to codify the authority of the government to order, to mandate the hospitals to accept the patients. So yeah, it's gonna be a big issue, but yeah, they are trying
That's
to.
hard to do.
Yeah.
If you don't have any staff or you don't have beds, then you can't. How can you mandate
Yeah.
it?
So yeah. So yeah. So both government should both not just order, but at the same time they need to take care of those kind of things. For example, the help of the infectious disease control. So yeah, and at the same time the financial aid too. So but it's still it's going to be a very big issue. So that's the current situation.
In the U.S., the hospitals are larger. Dr. Mori knows that 600 to even 1,000 bed hospitals are possible in the U.S. And most of the beds are not by chronic care. Actually, most of them are for acute care. So that's why they can shift over to something else, because the ward will they'll just not take other acute cases, and they'll just say you have to stay home. But we're in a situation now that yes, definitely there's areas that are collapsing because we are turning away patients also because all beds are full and there isn't staff to take care of them. So they're rationing resources. There's things that as serious as oxygen. So there's just not enough oxygen for the cases. PPE, that still continues to be a problem.
Yeah.
One thing about PPE is that I think the private sector here in the U.S. and actually in Japan too have stepped up big time, and companies like YKK, who we'll hear from a little later on in the program, and companies like Dex Cereals and Rico and a lot of other Japanese companies have helped with the support of PPE production, and other companies, Japanese and non-Japanese, have supported financially too. So, but one kind of question, kind of moving on from what we just discussed, is another big difference between Japan and the U.S. is the insurance system. I know Mori Sensei and Dr. Ku, you're not insurance experts, but I know the big difference is Japan has a nationalized insurance plan while the U.S. is all private. So can you talk about how insurance had an effect in the response to patient care and giving health care to the people who have been affected by COVID?
Can I start? Yeah, and as Yoshi-san said, that Japan has universal healthcare coverage. Government has the public option of the insurance, and all citizens are covered by any kinds of some types of insurance. And however, in terms of COVID, the payment, the reimbursement is directly from government. It's separated from insurance coverage. So it's more public actually. So all costs, because insurance, in terms of insurance, 13% of the costs out of pocket of patients, but in terms of the COVID, 100% paid by government, including the isolation costs. So this is because this COVID is treated in the Infectious Disease Act. So that's that was very good things for controlling the community infection, because patient should not have should not be afraid of the payment so they can go to hospital without any concern or financial concern. So that was good things.
Yeah, it's again an area where the United States is not doing so well. So luckily, we do have Medicare for the older patient population, and they're the ones that need more of the care right now. And so we do have a public option for patients that are 65 and older. And in general, most people in the United States will have that coverage. And they're the most ill in this situation. However, there are, of course, lots of people in the other age groups that are less than 65. And somewhere around 80% have insurance, and there's another 20% that don't. There has been government funds for hospitals to try and offset those costs, but they haven't been enough. They don't cover 100% of the COVID expenses if you don't have insurance. And also the hospitals are in a different mix now because many of the hospitals actually made most of their money on elective procedures and surgery and care. And that has been pushed out because of all the COVID cases. And so the hospitals are losing revenue, and it's still a problematic situation in the US. And it's disproportionate against the ones that don't have insurance.
Yeah, I think that the financial aspect of healthcare, not only for patients, but for hospitals and providers is a challenge that we'll be trying to balance out for a long time, right? So I know there's no one straight answer. But Dr. Modi and Dr. Ku, before we get into a Q&A session with our audience, just can you talk about the future outlook? I know we briefly talked about it, especially Dr. Ku, but can you talk about the future of vaccine distribution, development of new technology, contingency plans and procedures to make sure that we can avoid big challenges and difficulties if there's another pandemic? So Dr. Ku, we'll start with you from the American side.
Yeah, from the American side, there's at least hope here, and the hope could be pretty fast, actually. So I luckily was able to get my vaccine yesterday. So I was really happy to be able to get that. At Emory, we have a system that all the healthcare workers were able to get their vaccine, and they organized it very quickly through essentially a drive-through system. So many of you know that in the United States, we live in our cars. Everyone has a car. It's very car-centric. And so we were notified online that we could sign up for this. We filled out the whole questionnaire online, and we're given and we could sign up for a time slot, a 10-minute time slot that you can go to get it. Emory has a drive-through system over at one of our malls. It's called North Lake Mall, that is not being used very much these days. And so they organized this. So you just drive up, show on your phone that you have registered for that, and they go through that, and then they have something like 20 stations there. I drove up right to a station, opened the door, the person took my information, could scan it right away, and then I pulled down my sleeve and they gave me the shot. I couldn't choose between Pfizer and Moderna. They just said, you get what you get. But that's all right. They took my information, gave me a card, a CDC card that verifies that I received that and what time it is, and then stayed in my car the whole time. So the whole transaction of getting the shot was about 10 minutes total, including the drive through. And then they had us drive to a parking lot and sit there for 15 minutes. And they marked on the thing, and they had someone out there to just check on you, so that if you had any symptoms, anaphylactic shock or any of those types of allergic reactions, they could see you right away. and they made you stay there for 15 minutes beforehand before they would let you off, and they would check to see whether you had anything as you were driving out. And so the whole procedure for me took about 20 minutes, because that included the 15 minutes of waiting around. But I was seen right away. There was no waiting in lines or anything. There was always social distancing for everything. I think that procedure can be developed in many areas. And so in the US, we have a lot of empty parking lots right now. And so I think it could go very quickly. It just requires some organization. I'm hoping that the Department of Defense and things like the military are really very good at supply chain things and getting these types of organizations very quickly. I mean, they can build bridges in a day or two. So they should be able to do this if we got someone to organize that. My suspicion is that the CDC and the current people that are in charge of our COVID response are not used to organizing things. They were maybe appointed by political reasons instead of organizational, managerial reasons. But I'm hoping that in a couple of weeks, we can put that into place, and that's all that would be necessary. I think there's plenty of vaccine. And I know that for me, my life is completely different after I found that out, because actually it is unlikely that I'm going to have that situation. I will still mask when I go out because I don't know whether I'll be infected or not, but we'll be able to travel and be able to meet with students and things like that. So it changed for me radically in just a few days. And I think it can change radically for millions of Americans within a few months if we just organize.
Thank you so much. And Mori Sensei, I know the vaccination situation in Japan is much different, but can you talk about what's happening in Japan and the future outlook?
As I said, the authorization process is not finished yet. The last week, Prime Minister Suga said in a press conference, the government finished the all authorization process by the end of the next month, and but I think it may take some more time. So I think the first administration, first injection of the vaccine will be maybe in the spring in Japan.
Great, thank you so much. So going into our audience questions, we have a lot of questions concerning travel, actually. I think we're all chomping at the bit to be able to travel between the US and Japan, but what needs to happen in Japan and the US concerning COVID in order for travel to happen between the two countries? And also breaking news from our audience members, it seems that all international air travelers to the US will have to show proof of a negative virus test before leaving and arriving. So Dr. Koo, beginning with you, not just travel, but I guess public gatherings and events. How do you think the US, what needs to be done before travel and other types of gatherings need to happen?
Well, I think there are two responses. If you don't have the vaccine, then one needs to test and quarantine as appropriate. That hasn't been done in the States, and so that would help, I think. But if there is the vaccine and there is enough people that get the vaccine, you could have what they're calling a COVID passport and show that you either have the vaccine or that you've had COVID before, or you're testing negative. And I think that's reasonable to segregate people like that, so that gives them essentially the passport to travel.
Great, thank you.
What do you think, Dr. Mori?
In terms of traveling, actually now the Japanese government closed almost all borders with some exceptional traveling, but government asked for the 14 days quarantine after the entry of the border, and they also ask for the negative proof
Right.
You know, by the PCR test. And I think, but vaccine can be a game changer for this situation. So I expect that this year will be we can travel around in the later part of this year, I think, hopefully.
Great, thank you. We'll definitely keep our fingers crossed, Modi Sensei. But Modi Sensei, kind of switching the topic a little bit, do you think Japan benefited from having to deal with SARS before? I know that was about maybe 15, 20 years ago, which US did not have to deal with SARS too much, but was that a big factor in why Japan was able to navigate the COVID situation a little bit better?
Actually, I don't think so. In Japan, there are no patients of the SARS at the time, 2002 and 2003. And, you know, it was mainland China and other, you know, Southeast Asian countries. So, you know, we couldn't we couldn't use the experience of the SARS to the COVID response.
Great, thank you. Dr. Ku, a question for you now. So if rapid tests are so inconclusive, why are they still offered, do you think?
It's not that they're they're just less sensitive. So they're about 90% sensitive. So you're going to miss 10% compared to PCR tests. But still, it's good to detect the 90% that you can detect. So it's better than nothing still.
Great. Well, Dr. Modi and Dr. Ku, I know you're both in kind of the medical field and healthcare too, but you're also professors teaching. But Japanese elementary, middle, and high schools have face-to-face classes. But university students tend to be online, and same for it in US. Can you comment a little bit about how the academics and kind of classroom setting virtually and face-to-face in Japan and the US briefly? Let's start with Dr. Ku.
I teach online now remotely for all of 2020, since March. Personally, I think it doesn't work very well compared to others. Maybe it's just that I'm not learning the whole system. Zoom is great compared to nothing, but it's not the same as face-to-face. I get much more interaction with my students because I can call on them rapidly and they can hear each other's opinions much better. And so I can see whether they're learning or not. There's still a lot of students at the younger levels in the Atlanta area that are going to school remotely. And it's been hard for the parents because, you know, some of the parents have to go into work and others don't have to. So that's changed a lot. I do think that there's a social aspect or socialization aspect to many things. And I know that my students being able to quiz each other or discuss subjects helps their learning a lot. It doesn't have to come from me, but that interaction is hard to get. And so I think it's inferior, but you know, maybe that's all we have right now.
In terms of Japanese situation, I think it depends on the risk of infection, considering the very low incidence of the infection in Japan and the very low risk of the children if they got infected. It is reasonable that the face-to-face class in elementary school in Japan. So we don't have a big cluster of the infection in the elementary school or junior high school. So I think it's gonna be okay to have the face-to-face class in Japan in the current situation.
Great. Well, before we go into our closing remarks by our Vice Chair, Ms. Jessica Cork, we have one final question for both the Japan side and the U.S. side. So we actually have a good number of legislators from the government tuning in this evening from the American side. But what can the federal government or what can governments within city, county level, and then also legislators, what can they bring back to their health departments? What can they do at the community level to manage the current situation and then future outlook and make sure that this is kind of handled much better, both in Japan and US in the future? So Dr. Ku, I'll start with you.
Okay, I think it's mainly coordinated response, and a coordinated response doesn't have to take huge amount of resources. It just requires basic management. Right now in the Atlanta area, the vaccine is offered by different counties on different websites, and it's a free-for-all. I'll tell you that, like, my wife was able to get on the Fulton County thing, but not on the DeKalb County one. But the slots that are open just seem to come up in a haphazard manner. So all the people that I know that are getting the vaccine have had to play like the lottery. You just keep checking the website every hour, and sometimes something will come up and then you click on it. But otherwise you don't know, and there doesn't seem to be that coordinated response that could help a lot.
Dr. Modi, what do you think from the Japan side? What can government at different levels, what they can do?
In terms of the central government, the most important thing is a political leadership. The health impact of this infection is uneven depending on age. In other words, the risk of the younger generation is much lower than the old, but they still can be spreaders. So individual practice of the precaution and the benefits of these practices will be mismatched, which presents a challenge when encouraging people to follow preventative measures. To overcome this outbreak, we need a total effort from the whole community. So, this is why solidarity is important. To promote the solidarity, we need political leaders whom we can point to and say to our children, see, we have to behave like him or her. That's what we need in the Japanese central government, I think.
Great. Thank you so much to both of our panelists. I know there's a lot of other questions in the Q&A box. Perhaps we can have a 5-minute overtime after our closing remarks, but at this time, I would like to introduce the Vice Chair of the Japan American Society, Ms. Jessica Cork.
Hi, everyone. I'm Jessica. I'm Vice President of Community Engagement and Corporate Communications at YKK, as well as Vice Chair of the JASG. And I would just first like to thank Dr. Ku and Dr. Modi, and I'd like to ask everyone to give them a virtual round of applause. Such excellent information. I learned so much. I can see that there's so many more questions in the chat box there that we didn't get to, so I know that our audience really appreciated everything that you had to teach us. I would like to end today's session a bit on a positive note about the cooperation between our two countries in many ways, not just in healthcare. One interesting statistic that I have come across recently that all of us should be very proud of is that US employment by Japanese companies in 2020 amounted to 1 million American jobs. So that actually is including 600 Japanese affiliated companies in Georgia that employ over 36,000 people. And also, Japan is not only Georgia's #1 foreign investor, but the United States as well. Japan has invested $11 billion in Georgia and $645 billion in the US. And actually, of that, 20% was invested in 2019 alone. A lot of that is actually in manufacturing, and I know that a lot of our companies in Georgia represent manufacturing companies. But as of 2016, there was a record level of approximately 400,000 Americans that were employed by Japanese manufacturers in the US. And this is the largest by any foreign investor. And in fact, that has been a phenomenal increase of over 37% compared to 2010. I would also like to note that 2020 marked the 15th year anniversary of the Atlanta-Fukuoka sister city relationship, and 2021 marks the 55th anniversary of the Georgia-Kagoshima sister state and prefecture relationship. So we actually are very lucky in Georgia to have a lot of these sister city, and other sister relationships. These are only 2 out of 10. That we have. So I know that the future between our 2 countries and regions will continue to be bright. So with that, I would also like to thank the Consulate General of Japan and also our promotional partners. That includes Georgia Tech Center for International Business Education and Research, and Global Atlanta, 11 Alive, and the Georgia-Japan Legislative Caucus for helping to make this event possible, and also to everyone who is in attendance tonight. The Japan Society has a variety of events coming up. We have programming on Japanese innovation in agriculture, as well as in sports, diversity and inclusion, supply chain, workforce development, and so much more. So please visit our website, www.jasgeorgia.org, to learn about our membership and all of our activities. Thank you so much this evening for everyone coming, and we will see you next time. Thank you very much.
Great, thank you so much. Dr. Ku, Dr. Modi, if you're available to stand for just a few more minutes, as you can see, we have some questions that we weren't able to get to. If you'll be willing, we can go over some of these questions very quickly.
Yeah.
Okay, so thank you very much. Modi Sensei, I know you talked about this a little bit. So the vaccinations or the vaccines in Japan, are they the same as in the US? And are they Pfizer and Moderna, or is there other companies developing them?
Actually, Japanese government have the contract with the Pfizer and Moderna and the AstraZeneca. So, but the authorization process is not finished yet. So after that, we will have those vaccine from these 3 companies, I think.
Great, thank you very much. Next question is for both doctors, but we have actually a graduate student studying epidemiology and interested in furthering their career in studies in Japan. So is there a good time to try to pursue a career in public health research in Japan, and vice versa? Dr. Ku, is there a good way for students from Japan to study in the US to learn about public health research in the US? Dr. Ku, let's start with you.
Well, I can only really talk about the Atlanta area. We have a very good School of Public Health at Emory. There's a lot of statistics and operational research that is done over at Georgia Tech, which has very much implications to public health. And then, of course, we have the Centers for Disease Control with thousands of employees that work on public health. And I think normally that they would be, it's too bad they were supposed to be front and center on this pandemic, but I think due to some reasons they were held back from doing their job. So, but there's a lot of good things to study here.
Mori Sensei, what about in Japan? How can American students can study in Japan?
It's kind of a good idea. Now we have a very good the epidemiologist in Japan. Actually, personally, I myself studied in Emory. I did the MPH with the support of the Fulbright scholarship. So I studied in the United States public health, but yeah, it is good idea to do that in the same things in Japan. Yeah, that's good.
Well, this is true collaboration from the beginning too. So I'm so glad you shared that you studied in Atlanta, and hopefully we can invite you back to Georgia and to Atlanta sometime soon in the near future. So, Mori Sensei, we'll make it very short. And it's one question a piece for each of you. But the meat packing industry, the meat industry had a large number of COVID cases in the U.S., especially early on. Has there been a similar situation in the large food processing plants, such as Nippon Ham or Ito Ham or other food processing or manufacturing industries that has had some issues with COVID in Japan?
I have never heard of it. I don't know exactly the food industry has related to the COVID outbreak. I don't know.
Well, I think that's a good thing that you don't know much about that, as that means maybe there's not too many cases in those industries. So, and then Dr. Koo, so when you think about the reason of high number of cases in the U.S., our audience member thinks that one reason that the test many times in certain periods of time, and if a person tests a whole lot of times, that's the case, the actual number of COVID patients might be much less. Would this be the case? Or if yes, is there any data that we could check the actual number of patients?
One doesn't get COVID when you're tested. The testing is useful from a public health point of view to know how much it is spreading and how many it can spread beyond that, because there's essentially a contact thing. But there are other ways also to get surveillance data for that. One can use that data to find out where hotspots are and then react differently in the hotspots and react less severely in the places that have less. That wasn't done. So it's like if you know that someone has COVID, then it makes sense to quarantine them. But if you just look at the data and say, oh, it's hot here, and you let them all travel and have parties, then without even a soft lockdown, I think that is really good that Dr. Mori talked about the soft lockdown. Maybe that would work if we just recommended people to do that, but that doesn't seem to be the case in the US.
Great, thank you. Well, Dr. Mori and Dr. Koo, thank you so much. Can I ask for one last message of hope or kind of final words of wisdom as we kind of close tonight's program? Mori Sensei, let's start with you.
This situation is very difficult, but I think the vaccine will be a game changer in this year. So we can learn from each other through this experience. It's gonna this experience strengthen our systems, because this kind of pandemic will occur again because the mobility of the globalization is already we have. So after we restart the mobility in the global mobilization, we will have another pandemic in the future, in the very near future maybe. So we need to strengthen our systems, our society through this experience, I think.
Thank you very much. Dr. Koo?
Yeah, I would continue. This is a respiratory, it is spread through respiratory transmission. So I think wearing masks is a good thing, and one could try and do that. It's not that hard. I do agree with him that the vaccines are game changers, and these actually seem to be very effective and have very low risk compared to many others. So I would encourage you to get the vaccine.
Great. Thank you so much, Dr. Koo, Dr. Modi. Thank you, Ms. Jessica Court, for your comments about some positive figures and things happening between the U.S. and Japan. Thank you to the Consulate General of Japan, to all of our promotional partners as well. And we'll see you next time. Thanks so much. Stay safe, be healthy, and we'll see you soon.